Welcome to Same Surgeon, Different Light, Season 6. This is part of the Society of Thoracic Surgeons Surgical Hot Topics podcast series. My name is Sara Pereira, and together with my co-host Cherie Erkmen, we will meet cardiothoracic surgeons from across the spectrum of our rich community. We will explore their journeys, the obstacles they've faced in their careers, and the qualities that make each cardiothoracic surgeon distinctive and valued. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.
Same Surgeon, Different Light is brought to you by the Society of Thoracic Surgeons Career Center, where you'll find free access to cardiothoracic surgery jobs, career development tools, and professional guidance. Visit the STS Career Center at careercenter.sts.org.
Welcome to Same Surgeon, Different Light, Season 6. I'm Cherie Erkmen from Temple University, and I'm joined by my co-host, Dr. Sara Pereira from Indiana University. In this podcast, we focus on parts of surgical careers that you don't see on a CV. The decisions that people make along the way, the opportunities they choose to pursue or decline, and how those choices influence the work that they do and the lives that they build.
Thank you, Cherie. It's great to be with you today on Same Surgeon, Different Light. We're super excited to do this podcast today with Dr. Vaporciyan. So yes, we're interested in what drives these career decisions. How do they shape our careers over time? You know, I've never been afraid to make big decisions or change career trajectories in my career. Have you ever thought back about your years in thoracic surgery and thought about any of your decisions and if you would have changed anything?
Yeah, it's a really interesting question because you're just going through a transition, and I've been at the same place for the last 12, 14 years, and Dr. Vaporciyan will learn a little bit more about him, and where he's been, and it's a very big decision to move or to stay, right? And with that in mind, I'll go ahead and introduce Dr. Vaporciyan. He's professor of thoracic and cardiovascular surgery at the University of Texas MD Anderson Cancer Center. He serves as the vice president for physician practice integration, and his career spans thoracic surgical oncology, national leadership, and a sustained focus on surgical education. He served as the president of the Thoracic Surgery Directors Association, chair of the ACGME Review Committee for Thoracic Surgery, and as a director of the American Board of Thoracic Surgery. And much of his work is centered on how we train and assess cardiothoracic surgeons. So I'm so delighted to have you join us.
Thanks so much, Cherie. Thank you. And Sara as well. It's great to be here. I'm excited to talk about this because I think this is a part of careers that clearly we don't have time to go into the weeds with our trainees. They have so much to learn and we have them for such a short period of time. But this is the topic that tends to occupy my mentoring meetings with my trainees, especially as they're approaching graduation and right after they start their career. So I think it's a great topic to keep pursuing on this podcast for sure.
Dr. Vaporciyan, we're so excited to have you today. You know, I've looked up to you as so long with your leadership of TSDA, the board, ACGME Review Committee. I don't think anybody in our specialty that doesn't lead in these groups realizes how much work it is to be on some of these committees and workforces in education behind the scenes. But I wanted to start with what brought you into cardiothoracic surgery. So what first drew you to our specialty, and when did that shift from interest to something you knew you really wanted to pursue in terms of thoracic surgery?
Yeah, so I've had an interest in cardiac surgery since I was probably about 10 or 11. So my mom used to have a wall in the house where she would pin up newspaper articles. And growing up, I was born in 64. So growing up in the 70s, there was a lot of conversation about the first heart transplants and the cardiothoracic surgery and expansion. Cooley and DeBakey was on the cover of Life magazine, and that was a big deal, right? So as I was growing up, my interest centered strongly on cardiac surgery. I actually bought a copy of Gray's Anatomy when I was 12, and I destroyed the chapter on the heart and tore it to shreds. I still have that paperback version of Gray's Anatomy in my house. But then when I was in undergrad, I was lucky enough to land in a lab in the Department of Pharmacology that looked at ischemia reperfusion injury in dogs. And so I actually got to start working on oxygen radical, blockade to prevent ischemic reperfusion injury and these sorts of models, and really began to love that aspect of it and the research aspect of it. And so that was, I mean, I'd always known I was going to do it. But as I moved through that and then medical school, where I continued to do research in that department, and then when I broke out of my general surgery residency to do additional research in lung injury back at Michigan again, I started realizing that I did enjoy research as well. And at the time, general thoracic as a field was just beginning to come into light. There was literally only 2 programs in the country that were dedicated to training general thoracic surgeons when I was applying. And back then you would go into the match during your PGY3 year. And those 2 programs were Texas Heart and the Brigham with Sugar Baker. There was obviously some fellowships and super fellowships like Michigan, Dr. Oringer, Demeester, and USC, and then obviously you could go to Toronto and clearly get specialized training, but there wasn't very many. But I happened to be training at UT, and so I started getting interest in the general thoracic path, and it's a match, and I matched, and that's when it became something I knew I wanted to pursue as I was applying and I was starting to learn. Also sort of recognize that, research in cardiac surgery is an expensive operation to run for a hospital. They're not open to the idea of a 30% clinical faculty who spend 70% of their time doing research when they have to spend all that money operationalizing what it takes to do good cardiac surgery. So I realized that if I did want to pursue research, general thoracic probably offered more opportunities to marry that with the clinical side.
So you bring up a really important idea when, is your pathway driven more by opportunity, like what happens to be there? You happen to be in Texas, or more by intention, like I really want to do this and I'm just going for it. What would you say drove your early career?
Yeah, I think there is clearly a marriage of both. I don't think you can do one or the other only. I mean, some people may be able to, but certainly in a competitive environment, you are going to leverage the opportunities that come in front of you to move you to the head of the pack so you can land that residency and land that fellowship, right? I was not going to ignore an opportunity to work in a lab because I wanted to find a different lab that I might like a little bit better. That was a great lab. I'm taking it, right? Because I need to get some publications so that I can apply to medical school and I can apply to general surgery residency. So some of it is opportunity, especially early on. And I would say where I was able to transition and really start to focus on what I wanted to do, and I could share a conversation I actually had with Mark Oringer, who was influential in that when he was our visiting professor. And I was a junior assistant professor. And it was around the time I was going up for tenure. And again, I was leveraging opportunity because there's a clear path to get tenure at the University of Texas MD Anderson. I couldn't stray from that path. I knew what the currency was that I had to generate in order to get that promotion. So I didn't really stop to think as much about what I wanted as what I needed, right? Once I landed tenure, I will say that it got a little easier, right? Even though MD Anderson has a 7-year rolling tenure and I knew I was going to have to come up for it again, but still, it was like, okay, I landed tenure. I cleared that hurdle. Maybe I can back off, right? And look at this a different way. Might that have been different somewhere else where other aspects of what I was interested in were a pathway to tenure that was more routine? For example, education was not a routine pathway to tenure. Tenure at MD Anderson is what you can count, right? It is impact factor, it is publications, it is grants. That's what gets you tenure. So we have shifted that. It is now more scholarship, and clearly you can do scholarship in education. But at the time, that was the path that presented. So I capitalized on the opportunities that were available to me to get there. But going back to that conversation with Mark, it was right around the time I was coming up for promotion. I had landed most of the things I needed. I was pretty confident I was going to get tenure. Mark was a visiting professor. And in my conversations with him, I remember saying, I'm struggling, to land grants. I was doing lung injury research at a cancer center. I was about 20 years ahead of my time. I could have been doing it now with immunotherapy, but I was doing it then. I wasn't smart enough to be able to see the connection, and it was hard to land grants, to find collaborators at a cancer center. They were all interested at that time, the big thing was obviously VEGF inhibitors and these sorts of pathways, and EGFR was just coming in and HER2 was coming in. So targets were the big thing. So I remember saying it to him, like, I'm struggling with my career. My lab is not taking off the way I would hope to. And his response to me is, Ara, I've never had a lab. Do you think my career is a failure? To which I was like, no, you had a pretty darn good career. Yeah, I can see that. But yeah, he started allowing me to think about it a little bit differently. And as I said, the luxury of having landed tenure was an incredible relief, right? It took a lot of pressure off.
Dr. Vaporciyan, you in your career have really done everything from being the scientist, the clinical surgeon, and then with a really strong focus on surgical education. And I think that, these days in our specialties of cardiac and thoracic surgery, teaching our residents and fellows is so very difficult, as you know. And it's hard to convince our graduating senior residents and fellows to stay in academics, as they think that they'll need to be in a basic science lab or submitting grants. So can you talk a little bit about how you transitioned to be such a well-known, outstanding educator and, being really influential in our education societies?
Yeah, I will credit getting the training. So even to this day, when I not proposed that way, but proposed to my wife that I was going to get a master's in education. We just had our youngest. She was questioning my interest in doing that on top of being a surgeon. But we agreed. I moved forward with it at the University of Illinois, Chicago. I did not realize how impactful that would be, because it gave, it validated my voice when I spoke about education. Many people speak about education, but having a master's degree behind you, it helps. It also helped me communicate with non-surgeons because I began to understand the language of education. I talk about this when I became a chair, for instance. I learned about finance. Why? Because I need to speak that language with our CFO. And I need to generate budgets, and I need to understand productivity measures to hire. If you don't speak that language, they're not going to want to listen to you. The example I give is if I went up to one of my genomics partners here at Anderson and I made the comment like, hey, I've heard genes are really important in cancer and I'm really interested in doing some gene stuff, I'm sure they would just pat me on the shoulder and ask me to go get them tissue samples. But if I understand genomics and I understand targeted therapy and those metabolic and proteomic pathways that they're working on and how certain pathways are more important and more triggering than others, yeah, then they'll be more inclined to listen to me. And the same holds true with education. Once I had the master's, I could speak to people like Deb DeRosa. I could speak to educators who are, in the science of education, not just the visceral feeling of, I know how to educate. The other thing I learned is expertise is not generalizable. Just because you're smart in one thing does not mean you are smart in something else, even though there is a powerful unconscious bias to make us feel that way. And so I realized there were enormous gaps in what I understood about how to measure knowledge, how to assess somebody's skill, how to, do a gap analysis, how to design a curriculum, right? When I became program director, I remember I was asked to create a curriculum. I had no idea what that was. I thought it was a rotation schedule. In my mind, that's a curriculum, right? It wasn't until I started my master's, I was like, wow, that is so not a curriculum. Like it is so far removed from what a curriculum is. And so, yeah, I think what got me more and more interested was the more I learned about it, sort of opened up the Pandora's box and started to understand that there's a lot more to this than my assumptions had been, even as a student. It's essentially like asking a kindergartner to teach kindergarten class, right? Just because you finish kindergarten by no means qualifies you to teach kindergarten. And I was assuming because I had finished training in cardiothoracic surgeon, I was qualified to train them. And yet, as you dug deeper, you learn there's more to it than that.
It's interesting that you say that because I have my block schedule for the fellows for next year on my computer. And I was just thinking, I need to do more than just the block schedule. But you have to do the block schedule and you have to, you have to do the recruitment. You have to do all of the things required of a program director. But we're not really necessarily paid to do those things. And the institution says, you need to have a program, you need to have successful graduates. And then there's this big black box, and you may pour a lot of your energy into that, but maybe not get a financial return or the clear bump on your promotion dossier. So how do we make all of this effort worth it at the individual level, and your section level, and also broader, the institutional level?
Yeah, that is a great question. It sort of tags with leadership. I always found this interesting when I was going through the masters. There are 4 core courses, four credit courses. So 16 of the credit hours are done with these 4 courses. First one was curriculum design, totally makes sense. Another one was instructional methods, totally makes sense, right? Another one was assessment, totally makes sense. The fourth one was negotiating and change management. I'm like, what the hell is that doing in an educational master's degree? Yeah, it is all about negotiating and change management, right? Every program you try and push out as a program director requires you to develop a negotiating skill, requires you to understand change management, requires you to take busy clinicians and convince them that it is worth their while to spend a little time at the scrub sink beforehand teaching and filling out an evaluation form after the operation. All of that is change management. And so that was my first foray into leadership, actually, was that. In fact, at the Surgeons as Educators course, they also have a class on negotiating as well. And they carve out one of those 5 days to help you learn how to do that because it is so integral. Because you're absolutely right. This is leadership by coercion. It is not leadership through authority. All right. As a program director, nobody reports to you, right? You have no reporting structure. They are not obligated to do what you say. You have no financial allocation of funds to manipulate or entice or recognize or incentivize behavior. All of it is done through negotiating skills. And so your ability to form an amazing program is dependent on your leadership skills as much as your knowledge of education and designing a curriculum and all of that. And so that was sort of my first foray into leadership. And I actually saw it as an incredible stepping stone to becoming a chair. So when I was interviewing for the position of chair at Anderson, I leveraged what I learned as an educator in my role as a program director, and it became a perfect stepping stone. Those skills transferred in a seamless way to leading a department, to negotiating with a division head, to working with the OR to get block time. Those skills, with further reading and refinement and education, are the mainstay of leadership in my mind.
There are so many great little pieces of insight in what you just said that I find really useful every day in going from a program director to a division chief. How do you really truly convince surgeons to be patient at the scrub sink, right? So, in my mind, great educators just have this incredible emotional insight and situational awareness in the operating room. And I just love what you just said about all the aspects of education and being a program director that really make you a great leader. And it's often the people that aren't the basic scientists and the surgeon scientists in all of our divisions that are the best educators. And I think that's why I admire you so much, is that you've done all of those things and been so successful.
Expertise is not generalizable. Like,
That's right.
they are great research, and they can be great researchers and great educators. I think one of the things I remember learning was, the sort of the 4 stages of expertise, right? You are unconsciously incompetent first, right? And if you've taught a kid to drive a car, you know all 4 of these stages, right? At first, you don't know what it is you don't know, right? You go up to the kid and say, "Do you know how to parallel park?" And they're like, "Is that when the cars are right next to each other?" You're like, "No, that is parallel, but that is not parallel parking. Let me explain," right? You go through it, right? Then they move into consciously incompetent. The first time they try and parallel park, they're like, "Yep, I know what it is. I can't do it. I am conscious of the fact that I am incompetent at parallel parking," right? And then with a lot of practice, they become consciously competent. That's when you watch them park the car and you see the hamster turning in the wheel inside their head, right? They really have to think about it. Like, okay, turn the wheel to the left. Okay, but I got to wait till the car is just like, okay, now I turn it to the right. And then, okay, this is, and you can see them thinking it through, right? And then after they've been driving for a few years, they are now unconsciously competent. Right? They parallel park while they're talking to their friend in the passenger seat, and the radio's on and their phone just went off and whatever, and they can just do it, right? A key to being a great educator, the problem is that most great educator or most surgeons are unconsciously competent. They have forgotten how they do the things they do day in and day out. It's just become automated, right? Meanwhile, their trainees are somewhere between the unconsciously incompetent and the consciously incompetent phase. They're still figuring out what it is they don't know how to do, and they're still trying to learn how to do the stuff they know they don't do well. The trick to be a great surgical educator, in my mind, is to be able to move yourself back from unconsciously competent to consciously competent, to be able to break down a procedure into its integral steps, to be able to watch the trainee across from you and quickly assess where is their gap. Because that's the whole part of a curriculum. Essentially, you're constructing a mini curriculum. You are doing a rapid gap analysis, and then you are deciding which of those gaps you're going to address that day in that, quote, classroom in the OR. And then you're teaching specifically to that gap. And then you're assessing right afterwards, did they hear what I said? Did they learn? That's a curriculum from soup to nuts. That's what a curriculum is. You figure out what the gaps are. You design instructional tools to teach to those gaps. You design assessment tools to assess whether the gap has been addressed. And then the cycle begins again, right? And so in the OR, a key to being a good teacher is being able to identify the gap. I can lecture till my ears fall off or the trainees' ears fall off, but that's not a good, efficient educator. To be a really good, efficient educator, I need to identify that gap. And then I have to choose, because I guarantee you there'll be a lot of gaps. You can't teach them all at one operation. You're going to have to make a conscious decision about what I want to teach to today, what I want to bring them up. I can point out at the end of the day, I think you still need to work on this. We can get to that at a different date, but I want you to practice what we just went over today. Tissue plane identification, blind encircling of a vessel, right? Anatomy, whatever it is, you need to be able to find the gap so you can teach to it. Otherwise, you're just lecturing.
So
That's a great
yeah.
lead in to what we wanted to talk about next, which is training our future generation.
That's more
As I
difficult.
just debriefed on how to better place the stitch in the inferior vena cava to our chief resident a couple hours ago. So I'm sure you've had trainees that haven't been able to reach the unconsciously competent phase. So when you think about the trainees that you've seen succeed and those who've struggled, what separates them early on, and how do you progress folks through these different stages who are struggling?
Yeah, I would say first and foremost, my job is not to make them unconsciously competent. My job is to make them consciously competent, right? That last step from consciously competent to unconsciously competent can take 10,000 hours, right? That's expertise, right?
Right.
So one of the keys I tell all my trainees is you are not going anywhere and setting up your own shop. Your primary requirement of any position you land at after you leave here is good mentorship in the OR, in clinical decision making, because you're not there yet. All right. I'm sorry, you're not. My job, and it's written out in the board and it's written out in the ACGME, is to produce safe surgeons, competent surgeons, not experts.
Mm-hmm.
Safe, competent surgeons who I trust will do the right thing, even when that means saying, I'm not doing this case on my own. I need help. That to me is a competent surgeon. I want to impart within them the skills to continue to learn, to continue to better themselves, to get to that point where they're unconsciously competent. But my job is to get them to consciously competent. So I can reframe your question and simply say, what do I do with the person who doesn't get to consciously competent? Yeah, I mean, one of the biggest struggles we have is it's a short training program.
Mm-hmm.
In addition, your resources are limited, as we discussed earlier. You don't have gobs and gobs of time to spend with these trainees. You're busy too. You have requirements put on you. So you have to find it early, which means honest, difficult conversations early, right? And it is hard because I can tell you all my cardiac track trainees, yeah, they all feel inadequate that first 6 months. They're overwhelmed, right? It's all new to them. And they feel like, how in the world am I going to learn how to do this in the next 2 years? Like, this seems overwhelming. And Tony Estrella, partners with us across the street. Tony will calm them down and say, you'll get there. Don't worry. We'll get you there. And then, when I would interview them at the 1 year mark and the 1.5 year mark, you could see, yes, they had become consciously competent in many, many, many of the things, right? Because it does seem daunting at the beginning, just like you were training somebody to put that stitch in. Yeah, eventually that stitch becomes not the thing that's getting them freaked out. It's, where do I put my valve, in the tricuspid, where do I put my valve on the leaflet, right? When I'm trying to do a mitral repair, that becomes, and that's great because that speaks to their bandwidth. You move them through in a graduated way. One of the challenges we have, of course, is, there are a lot more surgeons training roughly the same amount of trainees, which means I don't have that true apprentice model where I can say, yeah, I've done 4 lobes with you in the last 2 weeks. I know exactly where you are in your progression of training. I know exactly where I need you to spend your time today. No, instead, it's, I did a lobe with you on the left side that was post-induction 4 weeks ago, and now we're doing a right lower lobe robotic, straightforward 2 centimeter mass, right? I have no clue where you and what you've done in the last 4 weeks with my colleagues. Mm-hmm. And yeah, we've tried to share information, but that is a very nuanced conversation, right? And so that, to me, is probably the biggest challenge of creating an efficient learning environment in the OR. It's easier in the clinic, right? Because you get to ask a lot of questions and see how they think. And you can quickly ascertain where the gap is. But in the OR, most of us have a similar way of handing over responsibilities, right? Take the vein first. If you can do that, okay, fine. Let's take the artery then, but that is a challenge going forward in our educational system. Yeah. And that becomes a challenge in identifying somebody early enough to intervene in an effective way.
And along those same lines, a question about the transition from residency and fellowship to practice. And we've all had experiences where someone may be great in training, but struggle in practice, or actually may struggle in training and do a great job and fly in practice. So there's a little bit of a disconnect between the environment we create in a training scene versus real practice. So how can we smooth that disconnect? How can we make the training more with fidelity to actual practice so that we can transition people through that really, really difficult first year?
Yeah, I thought about this. I see that as a 4x4 box, right? I've got great trainee, not so great trainee on one side, right? And then does great in their job and struggles in their job along, say, the x-axis, right? And you get your 4 quadrants, right? In my mind, the great trainee who does great in his job, yeah, that's easy. That's all dependent on the trainee. They know how to adapt. They were good at their training. They're good at their job, right? Similarly, the trainee who doesn't do so well in training and then struggles in their job, yeah, I'm pretty sure that's also trainee dependent, all right? There's some gaps there, willingness to learn, limitations in facing your own gaps and, addressing them, willingness, grit, whatever you want, right? The other 2 boxes, the ones you just pointed out, to me, could have a level of trainee in it, but I think that becomes more environment. I've seen phenomenal trainees who I thought, this guy's going to do great, and they get somewhere and they struggle. And I could see it being the environment a lot of times, you know, a constrained, a promise for mentorship that was not delivered, right? A RVU-based compensation model where hoarding is the norm, right? Meaning my ability to move forward in that journey to become unconsciously competent is stalled and delayed, right? Politics, right? I mean, just as a broad term, is everywhere, right? At the same point, I see for the other situation, the one who struggled in training, or let me just be more clear, who was perceived to be struggling in training and then did well in their career. Maybe some of that was a perception. Maybe some of it was a bias. Maybe some of it was an inability to recognize gaps and a huge reliance on a trainee educating themselves that some programs have. And so, I would say if you use the 2x2 box, the four square sort of analysis, you've got two of those that are probably more heavily dependent on the trainee, though not entirely, and then two that are more heavily dependent on the environment, though not entirely. But that's what I would say. And you're not going to land the right job, right? Obviously, of those two, the one that is more regrettable is the one where the training environment failed the training. Mm-hmm. Now, it may be that the trainee was not up to the task for that type of program, but that still is the responsibility of the program to recognize that and put in place what is needed to overcome that hurdle, even if that means more time. And yeah, that's a difficult and expensive conversation. I get it. Nobody's paying for that extra year. I get that. But it's hard. And to me, it is a societal responsibility.
Absolutely. You've been a really successful educator and now have a large leadership role at MD Anderson. And I wanted to hear about decisions that you've made, maybe your first 6 to 12 months as a new leader in your new vice president role. Have you made any decisions so far that you've thought have been really difficult or not gone as well, but you thought they were necessary?
I have not been in the role long enough to know if the decisions I've been making have been failing. Thankfully, they're moving forward. Do I regret any of the decisions? No, I don't at this point. Will I regret some of them? I'm sure I may as I move forward. I would say in my chair role, yeah, I had to make a lot. I became chair in 2015. 8 months later, we launched Epic. A year after that, I had to RIF 5% of my staff because leadership did not anticipate the delay in recovery of loss of revenue. Anybody who's launched Epic knows it's not a Nike swoosh. You don't get back that fast. It is a long, drawn-out process to recover. Yes, in the long run, it is an electronic billing machine. We know that. It is more that than a health record, but it takes time. We didn't recognize that, and I had to RIF 5% of my employees. Go forward another year after that, and Hurricane Harvey hit and devastated this city. That's when I learned about operations. And I started learning that, making assumptions about what I can do as a surgeon in the OR is really a narrow view of what it takes to run a hospital. And we learned that the hard way with Harvey, Yeah, all the surgeons live within 5 miles of the hospital. The staff, yeah, not so much. They're having to go with their flooded, low-lying homes, traffic, figuring out how to run a hospital was a huge eye-opener. Yeah. Fast forward another year, we had a CMS audit. 47 auditors from CMS descended upon us because we had a transfusion issue. Literally had to build a wall in a room overnight to satisfy one of the reviewers because they didn't like the way the room was set up. It was a nightmare for 9 months. Go forward another year and COVID hit, right? In the middle of COVID, I restructured our vascular surgery service, let go of 2 faculty, changed the entire way we do vascular surgery at MD Anderson, brought in a PSA agreement with the University of Texas across the street. All of those had enormous, challenging decisions to make, did not get them right, learned about change management and the idea of an iterative, thoughtful, slower approach to change management. Harvey and COVID did not offer the opportunity for a slow, what we call drip change management. Like we had to adapt quickly. On the other hand, the vascular restructuring, yeah, I had time with that one. All right. I could think about it. I could work on it. I could introduce it slowly. I could find out. I could adapt it. I could make changes. All right. Right now, I'm introducing a new form of recognition plan at MD Anderson. That's money. You can imagine that generates some resistance and requires a very thoughtful approach to change management. So, yeah, there's been a lot of challenging decisions. But at the same time, that's really kind of the fun of the job at this point. Yeah, I'm able to do things and change at scale that, I changed at scale as a department chair, then I changed at scale at a programs director scale, you even change at scale when you're in the operating room as a leader, right? We are leaders in every environment. And so understanding how you can produce that change in an effective, efficient manner is crucial, I think, to everything we do.
So we've been able to see a lot of the successful changes that you've had in your career and influences at a national level through our societies. But I'm interested in an idea that you felt really strongly about. You had your passion, you had everything going for you, but it just didn't take hold. Do you have an idea or an experience where it just never flew? Tell me about it.
Yeah, I mean, the hardest one for me to swallow, and it was a big learning experience. And some people on this phone call or who listen to this podcast will know this instantly, but I, on the board, wanted to address how we assess clinical decision making. And I made it pretty much my mission when I got onto the board that was going to be something I was going to talk about. I didn't know how I would do it, but I have my own personal concerns about oral exams. All right. I feel they have clear limitations. And as I said earlier, the master's degree allowed me to voice those concerns in the language of an educator with data and science to back it up. In the end, even though we piloted it a number of times and tried to move it forward, it was not adopted. And I would say in thinking about that and learning about it, one of the books I read a lot of business books, and one of the best books I've read recently on change management is a book called Catalyst by Jonah Berger. In it, he describes 5 types of roadblocks that get in the way of change management and how to set yourself up to address them, anticipate them, be ready for them. One of those roadblocks is distance. How far you expect somebody to move through that change you're asking them to make. It is very hard when somebody is positioned on the 10-yard line to take them all the way to the other end zone. It is a lot easier to move them 30 yards downfield. I tried to move too far, too fast. And in retrospect, I learned that lesson. And I applied that lesson learned to when I developed the recognition model here at Anderson. I said, we're not going to take it all the way. You get to keep half of the model the way you've always done it. I'm going to play with the other half, and I'm going to put criteria in place to get it there. And we're just going to move you that much, right? And it'll be an iterative process. I did not recognize that when I did it, I was ideological. I was, I got a master's in education. They should listen to me. No, I needed to be thoughtful about this and understand that this is a huge shift for an entire society. And to ask them to do that in one fell swoop was a bridge too far, and needed to reconsider the change management. And that's again why I say change management it's everywhere. Think about talking to a patient. That's change management sometimes, not in an intentional way, but getting them to understand and be able to make a decision. You have to get them to see what you know and do it in a way where they can understand it. Doesn't always mean they'll change their mind, but at least they're making an informed decision.
So you're pushing innovation in education and assessment. And I think we all realize that we can improve. Where do you think we're headed in education and surgical education in particular for the future?
I think we are going to have to start leveraging AI, generative AI, in helping us do those tasks that we currently use faculty time, trainee time to do. I know, for example, the board is looking at AI generation of questions. I think this is great. I think we can probably step up question construction very efficiently. Are we going to take the human out of it completely? No, absolutely not. But can we speed the process up? No different than my ambient listening technology in the clinic. I don't just tell Abridge to generate a note and then walk away. I look at the note, right? I make sure it makes sense before I sign it. Same process we'll take here, right? This is going to allow us to speed up the efficiency of some of these things. But there's even more. I mean, right now, one of the New England Journal articles that came out a number of years ago on clinical skills was looking at surgeons performing a jejunostomy during a bariatric operation, right? These were hand rated by surgeons, viewing the video and scoring it. Yeah, we're going to be able to get rid of that. We're going to be able to rapidly and more efficiently do this. And we're going to be able to marry it with their own data. Eventually, down the line, in a protected space, we're going to say, how is this surgeon doing and how are their outcomes doing? I see this as being, in education, assessment has tiers. At the bottom level is they know how, right? That means they can just regurgitate facts. They know, right? Then the next level is they understand, right? This means they can explain the relationship between two things. And then the next level up is shows. And that's where they actually do it and you get to watch them while they're doing it, right? And that's usually as high as we go in our educational assessment, somewhere between shows and understands. But the top of that pyramid is does. That's really what you want, right? You want to know, if I'm not looking, is this surgeon doing what I taught them? And are they doing it safely and effectively and consistently applying what they learn? That's the pinnacle of educational assessment, does, in one model. I would love it if AI could do that for us. Your first 30 cases after you leave, all filmed, all judged by AI, you get feedback. It says, you're not ready. You need to be proctored for 10 more cases. Fine. I'm not saying I take away your license, but geez, wouldn't it be wonderful if we could effectively apply human resources where they're needed in an efficient manner without having to expend tons of resources reviewing videos of films, all of that, right? And I think this is where we need to be going. The other thing is, let's be honest. I remember when my wife first introduced to me that she got ChatGPT, I was irritated, because when I was a medical student, the thing that made me shine was the fact that I could memorize shit and speak it back, right? I was really good at memorizing and regurgitating information. Yeah, you don't need to do that anymore, right? And in fact, I would kind of blame you if you relied on your memory when you can look up exactly what the most recent update is on open evidence. In fact, in geriatrics medicine, They allow them to bring their phone into the exam, and they allow them to use their phone when answering the questions. Because guess what? I would rather they not guess. I would rather they get the right answer, right? Yeah, that puts the bar a little higher, but it also requires them to be efficient users of this technology in the delivery of care. Is that where we should go? Yeah, there's some things our trainees better know that they shouldn't have to look up, like anatomy. But seriously, do I need to have them memorize the staging system? Like, come on.
Right.
I don't want them to misguess.
And it's interesting that you're talking about the assessment being an AI process, and perhaps the bias that we have with our trainees. Maybe that's actually something, or sometimes hearing it from a computer is easier than hearing it from your mentor, right? So it
Be wary.
may be better. You never know.
Be wary. You know the adage, crap in, crap out.
Yes.
And unfortunately, there are a number of examples of AI models reproducing bias, right? Because they learned off a training set that contained bias, right? That's why I think the best way to do it is get to the does level. Have my AI review you doing cases, and at the same time, it's monitoring outcomes, all right? So it's not relying on me to come in afterwards and say, oh, that case was done poorly by AI. I published a study with Dr. Antonoff and I a few years ago, a number of years ago, where we made a video, all right, of a trainee performing a distal coronary anastomosis. You can't see anything but their hands. We then sent that video out using a rating scale that I developed as part of my master's thesis. We provided a blurb about the trainee. In that blurb, we said the person was a third year resident in an I6. They'd done about 20 distal anastomoses. This is about the fifth one you've done with this person, and you have to rate them. Please watch the video and use it. And we did it under the auspices of two separate rating scales. One was one where the rater can make judgments, and the other one was a yes-no categorical scale. The categorical scale being the one I developed, the other one being one that Jim Fan had been using, at the boot camp. And so the premise of the study was we want to see which one works better. All right. Well, we didn't tell them that there was a second randomization. That half of the people got the description of the individual using male pronouns. The other half got the same description, exact same video, but with female pronouns. And there was a difference. They were looking at the same video, all right? And the difference was the same regardless of the rater's gender or sex or whatever, all right? And was it a demonstrable one that would have resulted in that person not graduating? No, the impact was small, but it was there, right? Right? So I think a carefully constructed AI assessment tool could avoid some of that. All right. But yeah, it's going to take thoughtful educational leaders. I'm done. All right. I'm 62, but I'm happy to help. But we need other people who understand this to move this field forward for sure.
We can tell how heated our discussions of AI will be amongst the board in future years. Ara, we really appreciate your vulnerability and honesty and all of the great insight you've shared. And we're running short of time. And I really want to ask you one question that I think about a lot. And, we often sit in these heated boardroom conversations and we second guess our decisions and what we've done during the day. And that obviously impacts our personal life. And I'm wondering, one, what you do to unwind at the end of these hard days. And two, if you ever bring your work and decisions home to your family.
Oh, yeah. Yeah. So my wife is amazing. She is an incredible partner, but she also knows when work is coming home. And after 25 years of marriage, she understands when, okay, it's going to be just go sit and watch TV. I'm going to go in the other room and read, right? I don't need you to be with me. Just go deal with what and I recognize that for her as well. Thankfully, we share a lot of passions, but also have our own. I like to woodwork. I like to read business books. She does not like to read business books. She does not woodwork. All right. We like to travel together. We like to eat. We foodies. We both like to cook. That being said, she understands that she will cook more than I will because I'm here and she's there. At the same time, she and I understand that I chose a calling, not a profession. We all do. She gets that. She understands that, but she also tries to level set me, not tries, does level set me and says, hey, your calling is starting to impede on your well-being. You need to realign and recalibrate here. And in that regard, as you all know, you get into it deep and you lose track. And you need that voice that you trust who sits at the table and isn't just agreeing with you when you book that extra case on Saturday or you stay late for that extra meeting or you call in, right? And so I don't see how I would do it without her. I could see myself just going down that path of just being all work, and that wouldn't be fun at all.
What was your last woodworking project?
So I build speakers for my trainees. So that was probably my last one, little wooden speakers that they can put their iPhones in.
Cool.
Yeah, they look like this. So
Awesome.
that table, I built that. But I lost my wood shop. We moved into a apartment, but my wife has promised me we'll get it back. So yeah, so it's fun.
That's awesome.
I like creativity. We all do. We're surgeons, right? We like to be creative. That's part of the job. So I like doing things that are creative, as does my wife, as a painter and a graphic designer. So, well, thank you.
Thank you. We really appreciate you joining us on the podcast today and all of your insight. I'm going to think about this unconscious competence again as I speak to their residents here shortly at a conference.
And I like the comment, leadership by coercion. I'm going to use that and put that into play.
Maybe the better phrase is leadership by negotiation. How about that?
All right. All right. Thank you so much. All right. We're so happy to have you.
Thank you very much.
Thank you, everyone, for joining Same Surgeon, Different Light.
And thank you to STS for hosting our podcast series.
Yes, thank you. Take care, guys. See ya.
This has been Same Surgeon, Different Light, a podcast brought to you by the Society of Thoracic Surgeons. Thank you for listening. If you like this podcast, please rate it 5 stars and let your friends, trainees, and colleagues know about it. On social media, you can use the hashtag #TheFaceOfCT Surgery. And for more information about the Society of Thoracic Surgeons, you can go online at sts.org.